Hello everyone, I am Dr. Mithilesh Kulkarni. I am Assistant Professor in the Cardiology Department at Unmicrc Institute of Cardiology and Research Center. Today I will be talking about management of diabetes in heart diseases. So let's start. I have divided my talk in the following headings. First, I will be talking about a preamble, that is, why is it necessary to control the sugar in heart diseases patients. Second, we'll be talking in short about the pathophysiology of diabetes mellitus and heart diseases. Then I will move on to the management of diabetes mellitus. It includes the various oral hypoglycemic agents and the insulin. And lastly, I would like to talk about the recent guidelines for the management of heart diseases and diabetes. Okay, so let's start. The introduction. The incidence of diabetes mellitus has increased and quickly has become one of the most prevalent and costly chronic diseases all over the world. The diabetes mellitus and cardiovascular diseases is the most prevalent cause of morbidity and mortality in diabetic patients. Cardiovascular risk factors such as obesity, hypertension and dyslipidemia are common in patients with diabetes mellitus, placing them at increased risk for cardiac events. Biological mechanisms associated with diabetes mellitus will independently increase the risk of cardiovascular diseases in diabetic patients. So management of type 2 diabetes, if we see it over a period of time, initially, that is prior to 2008, we used to say that the HbA1c, the lower the better. From the period of 2008 to 2019, it became like the HbA1c, the lower the better, but it should be without weight gain, hypoglycemia and side effects. And 2019, the concept has come that the cardiovascular risk, including the blood pressure, LDL cholesterol, the glucose lowering agents of proven safety and efficacy. Now, what are the risk factors for cardiovascular diseases? I will tell you one by one. First is the obesity, second is the hypertension, third is the dyslipidemia, fourth is the diabetic cardiomyopathy, fifth is the cardiovascular autonomic neuropathy, and last is myocardial infarction and diabetes mellitus. So now we come to the pathophysiology of diabetes mellitus and a heart disease patient. So as we can see, a patient who is having a diabetes mellitus will have hyperglycemia, and this will also have excessive free fatty acids and insulin resistance. Overall, this will lead to the oxidative stress, the protein kinase C activation, the receptor for advanced glycation end products activation. So because of the hyperglycemia, these are the three things which are happening. I would like to repeat it again. First is the oxidative stress, second is the protein kinase C activation, and third is the RAGE activation. So what will happen is, because of the combined effects on the endothelium, the nitric oxide will decrease, there will be increased activation of NFK beta, increased angiotensin 2 and increased activation of protein 1. So final result of uncontrolled diabetes will be vasoconstriction, leading to hypertension, vascular smooth muscle cell growth, inflammation which causes release of chemokines, release of cytokines, expression of cellular adhesion molecules, and thrombosis, that is hypercoagulation, the platelet activation, decreased fibrinolysis. So if we come stepwise, because of the diabetes mellitus, there is increased hyperglycemia, there is excessive free fatty acids, there is insulin resistance, which will lead to the damage of endothelium and which ultimately will lead to three consequences. First is the vasoconstriction, second is the inflammation, and third is the thrombosis, which ultimately leads to the atherogenesis and arterial thrombosis. Now the continuum of cardiovascular risk factors in type 2 diabetes. After the onset of diabetes, as we see, if the glucose is not controlled, ultimately it leads to the complications, which ultimately leads to the disability and death. And what are the risk factors and what are the pathophysiological changes which are happening in the body? There is atherosclerosis, there is hyperglycemia, hypertension, retinopathy, nephropathy, neuropathy. As we all know, classically we have retinopathy, nephropathy, neuropathy, atherosclerosis, and ultimately it leads to the disability and death of the patient. Now, diabetic heart failure. This is an important risk factor because day by day we are seeing more and more heart failure patients. So a patient who is having diabetes will have impaired glucose handling insulin resistance, will lead to autonomic dysfunction, will lead to diastolic and systolic dysfunction, will lead to diabetic heart failure. So a patient who is having diabetes is more prone to develop heart failure, and as we all know that heart failure itself is very challenging to treat. I would like to repeat the pathophysiology again. Because of the diabetes, there will be impaired glucose handling, insulin resistance, autonomic dysfunction, oxidative stress, inflammation, hypertension, ultimately leading to the diastolic dysfunction, systolic dysfunction, fibrosis, decreased perfusion, and ultimately leading to the diabetic heart failure. Now, what is the evidence for current cardiovascular disease prevention guidelines? The diabetes mellitus evidence and guidelines. This is the natural history of type 2 diabetes mellitus, that is after the onset. As we increase the duration in years, either we have a pre-diabetes, that is just borderline between normal and diabetes. Then comes the type 2 diabetes. In type 2 diabetes, we have both the microvascular complications and the microvascular complications. So we can call it as a spectrum. It starts with pre-diabetes and later on leads to the microvascular complications and the macrovascular complications. So evidence for current cardiovascular disease prevention guidelines, we come to the pre-diabetic conditions. Coming to the diagnostic criteria for the pre-diabetic conditions, as we know, the risk factors are impaired glucose tolerance and impaired fasting glucose. The impaired fasting glucose is defined as levels of 100 to 125 milligram per deciliter of fasting glucose, and impaired glucose tolerance, that is the IGT, is defined as after 2-hour glucose concentration of either 7.8 to 11 millimole per liter or 140 to 199 milligram per deciliter. This is following a 75 gram of OGTT, that is oral glucose tolerance test. Now coming to the pre-diabetic condition, that is a benefit of lifestyle modification. This is a study in which 531 Asian Indians with impaired glucose tolerance were randomized to placebo, metformin, lifestyle modification or lifestyle modification plus metformin for 30 months. It was found out that the lifestyle modification and metformin will reduce the incidence of diabetes mellitus with no additional benefit from their combination. So coming to the evidence for current cardiovascular disease prevention, the diabetes mellitus management. The diabetes mellitus, the risk of myocardial infarction in an East-West study. Here we can see that the patients with diabetes mellitus but with no CHD experience a similar rate of MI as patients without diabetes mellitus but with CHD. Now what is the diagnostic criteria and guideline recommendations? Impaired fasting glucose, as we already discussed, if the levels are between 100 to 125 milligram per deciliter, and impaired glucose tolerance, that is IGT, is defined as a 2-hour plasma glucose or a 75 gram oral glucose tolerance test. The level, if it is between 140 to 199, then it is labeled, and if the HbA1c is between 5.7 to 6.4. So ADA criteria for diagnosis of diabetes mellitus: if the HbA1c is more than 6.5, the test should be performed in a laboratory using a method that is certified and standardized to the DCCT assay, or if the fasting is more than 126 milligram per deciliter. Fasting is defined as no caloric intake for at least 8 hours. This is important because in OPD we need to tell the patients, if you have to come for a fasting blood glucose, then they shouldn't have had any meals for the last 8 hours. And 2 hours plasma glucose, that is the postprandial or the PPBS, it should be more than 200, then we'll label them as diabetes mellitus. Again, the test should be use a glucose load equivalent to 75 grams of anhydrous glucose dissolved in water. Or if the random blood glucose is more than 200, then we'll label it as diabetes mellitus. So again, I would like to repeat. So when will we call a patient having diabetes mellitus? First, if the HbA1c is more than 6.5%. Second, the fasting is more than equal to 126 milligram per deciliter. Or third, 2-hour plasma glucose more than 200, that is postprandial blood glucose more than 200, or if the random plasma glucose is more than 200. Any of the above, if the criteria is fulfilled, the patient will be labeled as a patient having diabetes mellitus. Now coming to the management of diabetes, before starting the management, I would like to tell that it is not only the drugs and insulin which are important for the management of diabetes. As with any other diseases, step 1 will be patient education, step 2 will be diet, step 3 will be exercise, and step 4 will be the medication. So if we give them all in together, then we see that we get a synergistic effect. I am again repeating it. We need to teach the patient what is good for them, what is not good for them, what is having high glycemic index. Second, we need to tell them about diet. Third, we need to tell them about exercise. And last but not the least, if still the blood sugar is uncontrolled, then we need to start them on therapy, that is the oral hypoglycemic agents and insulin. So how do you manage a patient of diabetes? So these are the various drugs which are available for the management of diabetes. First is the bigonides, the agent name is metformin. Second is sulfonylurea, in which we have first generation and second generation. In the first generation we have acetohexamide, chloropropamide, tolazamide, tolbutamide, and in second generation we have glibenclamide, glyburide, glipizide, glimepiride and gliclazide. Meglitinides are there, in which there is ripaglinide, nateglinide. In thiazolidinediones we have rosiglitazone, pioglitazone. Alpha-glucosidase inhibitors we have acarbose, miglitol, and we have incretin agonists like exenatide, liraglutide, and last but not the least, that is the DPP4 inhibitors. We have sitagliptin, vildagliptin and saxagliptin. So these are the various group of drugs, that is the oral hypoglycemic agents which are used in the management of diabetes. Again, I would like to repeat the name of the groups. First is the bigonides, second is the sulfonylureas, in which we have first generation, second generation, then we have meglitinides, then thiazolidinediones, then alpha glucosidase inhibitors, then incretin agonist, and then DPP4 inhibitors. So now coming to the drugs and the mechanism of action. Insulin, the mechanism is it causes activation of insulin receptors and it has got various effects on multiple metabolic pathways. Next is the metformin. Metformin acts by reduced insulin resistance, mostly by decreasing the gluconeogenesis. Next is the sulfonylureas. The sulfonylureas have insulin secretagogues by activation of the SUR, that is SU receptor, unit of ATP sensitive potassium channels. Then thiazolidinediones, insulin sensitizers by the activation of PPAR, that is the peroxisome proliferator activated receptor gamma. So all these drugs, that is the 4 drugs, insulin, metformin, sulfonylurea and thiazolidinediones, have been called as the traditional oral hypoglycemic drugs. And what are now coming to the novel drugs? In novel we have 3. First we have DPP4 inhibitors, then you have the GLP-1 receptor agonist, and next we have the SGLT2 inhibitors. So let's see them one by one. The dipeptidyl peptidase 4, that is the DPP4 inhibitor, they will act by inhibition of DPP4 and subsequent conservation of native human GLP-1 in its active form. The GLP-1 receptor agonist, they will act by activation of the GLP-1 receptor at high pharmacological concentrations. And next is the SGLT2 inhibitors, that is sodium glucose cotransporter 2 inhibitors. They will act by inhibition of active resorption of glucose and sodium, which is performed by the SGLT2 in the proximal convoluted tubule of the kidney. We should also know what are the various adverse effects of these drugs which are used to treat diabetes, because if we start a patient on some drug and he comes up with some side effects, then we should be able to identify that these side effects are because of the particular class of agents. I would like to go through them once. First, let's come to insulin and analogs. The example of drugs, as we all know, is regular insulin. The adverse effects of insulin can be like hypoglycemia, weight gain, insulin allergy, lipodystrophy at the injection site. Now coming to the sulfonylureas, example of drugs in this category as we already discussed is glibenclamide. Again, the adverse effects are hypoglycemia, weight gain, cardiovascular risk, rash, cholestatic jaundice, bone marrow damage, photosensitivity. Next is the meclizine. We have repaglinide. The side effects are hypoglycemia, sensitivity reactions. Next comes the bigonide like metformin. That has gastrointestinal side effects and lactic acidosis. Next group of drugs is the GLP-1 agonists like exenatide. We have gastrointestinal side effects, pancreatitis, risk of cancer and cardiovascular events. DPP-4 inhibitors like saxagliptin, again known to cause pancreatitis, risk for cancer, acute hepatitis and kidney impairment. Thiazolidinediones like pioglitazone may cause hepatitis, cardiovascular risk, bladder cancer, water retention and weight gain. Dual PPAR antagonists like saraglitazole will cause arthritis, asthenia and pyrexia. The alpha glucosidase inhibitors like acarbose will have side effects like gastrointestinal side effects, hepatitis, and amylin analogs like pramlintide will have hypoglycemia, allergy as side effects, and SGLT2 inhibitors like dapagliflozin, like canagliflozin can have side effects like glycosuria, cardiovascular concern. So a point I would like to share with you is that recent guidelines has updated they have recognized glucagon like peptide 1, that is GLP-1 receptor agonist, and the SGLT2 inhibitors, that is the sodium glucose cotransporter 2 inhibitors to the repertoire of anti-hyperglycemic agents for their benefit as either first line therapy or addition to metformin. We'll discuss about this in detail in the coming slides. The multifactorial treatment algorithms for patients with type 2 diabetes. There are some important points which I would like to discuss. When evaluating patients with diabetes, anthropometric measurement should be obtained and the clinical components of medical, obesity and diabetes history should be assessed. Next, providers should screen for complications of diabetes using additional testing as needed. The assessment of cardiometabolic risk and diabetes associated comorbidities. And last, the evidence-based multifactorial treatment algorithms are used to treat patients to the appropriate goals, avoiding therapeutic inertia. So what are the different algorithms for treating diabetes? As we have discussed, the treatment always includes first the lifestyle therapy, including medically assisted weight loss plus metformin. And the individual goals should be HbA1c should be less than 7 for most patients, HbA1c less than 7.5% for monotherapy, more than 7.5% dual therapy, and if it is more than 9%, then we require endocrinology. So if a patient has established ASCVD disease, we add GLP-1RA or SGLT2 inhibitor. Next, we add GLP-1RA or SGLT2 inhibitor, and ultimately we add the DPP-4 inhibitor, basal insulin or pioglitazone. Second, if the patient, so this is one approach. Second approach is that if the patient is having CHF or CKD predominates, then we add SGLT2 inhibitor, then we add GLP-1RA, and at the last we add DPP-4 inhibitor, but not saxagliptin or basal insulin. So these are two different approaches, one patient having ASCVD diseases and second one with a CKD predominant. So all glucose lowering medications used to treat type 2 diabetes are not equally effective in reducing CV complications. We need to remember that SGLT2 inhibitor and GLP-1RAs are associated with reduction in MACE, like the gliflozin, GLP-1 agonists like the incretins and mimetics, whereas the DPP-4 inhibitors like the gliptins, what we talked about, the sitagliptin, the vildagliptin, the DPP-4 inhibitors are not associated with reduction in the MACE. DPP-4 inhibitors don't reduce the risk of CV event, yet are the most widely prescribed new glucose lowering drugs. Yes, this is a paradox that although DPP-4 inhibitors don't reduce the risk of CV event, but yet they are the most widely prescribed new glucose lowering drugs. Now SGLT2 inhibitors and the GLP-1 agonist, they have a triple mechanism of action. First, they will cause arterial protection. Second, they will cause glucose lowering actions. And third, they will have a cardiac protection. So what are the pharmacological treatment? We will see the advantages, disadvantages and the considerations. First, we will talk about the SGLT2 inhibitors. The SGLT2 inhibitors is that the advantages of SGLT2 inhibitors is that they have a low risk of hypoglycemia, they help in reduction of weight, reduction of blood pressure, effective for all stages of diabetes mellitus, CV benefits, they cause a reduction in the progression of renal diseases and reduce hospitalization for CHF. The disadvantages of SGLT2 inhibitors are the genital mycotic infections can be a possibility. They do cause bacterial UTI, volume depletion, increased LDL cholesterol, increased risk of amputation, increased risk fracture and increased risk of DKA, but again this is rare. What are the special considerations while giving SGLT2 inhibitors? The efficacy falls with GFR and adjusted dose is required, or we need to avoid them in CKD. Now coming to the GLP-1 RAs, what are the advantages of GLP-1? First, the low risk for hypoglycemia as a monotherapy, helps in the reduction of weight, helps in the reduction of blood pressure, helps in the reduction of postprandial glucose, reduction of CVD risk factors, CV benefits and renal benefits. The disadvantages is that the gastrointestinal side effects are there, leads to the increase in the heart rate, inconvenience of injection. And the special consideration about the GLP-1 RA is that for some agents it will require to adjust the dose like in patients of CKD. Now coming to the diabetes mellitus treatment to reduce the heart failure risk, the SGLT2 inhibitors like the empagliflozin, canagliflozin, dapagliflozin to lower risk of heart failure hospitalization if eGFR is more than 30 ml per minute per 1.73 meter square. Metformin in patients with diabetes mellitus and heart failure if the eGFR is more than 30. GLP-1 RA and DPP-4 inhibitors sitagliptin and linagliptin have a neutral effect on the risk of heart failure. Insulin treatment in heart failure. DPP-4 inhibitor saxagliptin in heart failure is not recommended. Important point we all need to understand, the DPP-4 inhibitor saxagliptin is heart failure is not indicated. Thioglitazones like the pioglitazone and rosiglitazone is not recommended. Now coming to the ADA criteria for testing of diabetes mellitus in asymptomatic adult individuals, primary prevention, all overweight adults with BMI more than equal to 25 kg per meter square with another risk factors like physical inactivity, first degree relative with diabetes mellitus, member of high risk ethnic population like African American, Latino, Native American, Asian American and Pacific Islander, women who deliver a baby more than 9 pounds or were diagnosed with gestational diabetes mellitus, hypertension defined by BP more than equal to 140 by 90 mm mercury or a therapy for hypertension, HDL cholesterol less than 35 mg per dl and or triglyceride level more than 250 mg per dl. Continued, all adult overweights more than 25 BMI with another risk factor like women with PCOS, that is polycystic ovarian syndrome, HbA1c more than 5.7%, IgT or IFG on previous testing, other clinical conditions associated with insulin resistance like severe obesity, acanthosis nigricans and history of cardiovascular diseases. In the absence of above criteria, testing should begin at the age of 45 years. Important, if the patient is not having any of the above mentioned risk factors, the testing should be started at the age of 45 years. If the test results are normal, the testing should be repeated at 3-year interval with consideration of more frequent testing based on initial test results and risk status. What are the AHA ACCF diabetes mellitus recommendation in the secondary prevention? The class 1C recommendation is that the care for diabetes should be coordinated with the patient's primary care physician and or endocrinologist. 1B recommendation is that the lifestyle modification including the daily physical activity, weight management, blood pressure control and lipid management are recommended for all patients with diabetes. And 2A recommendation is metformin is an effective first line pharmacotherapy and can be useful if not contraindicated. Again, coming to the secondary prevention, 2AC recommendation is that it is reasonable to individualize the intensity of blood sugar lowering intravenous based on the individual's patient's risk of hypoglycemia during treatment. 2BA recommendation is that initiation of pharmacotherapy interventions to achieve target HbA1c may be reasonable. A target HbA1c less than equal to 7 may be considered. This is again a 2C recommendation. Thank you.